an oversight group for advancing care together. It's been great. I know that I'll get a chance to see folks that are on the phone at our meeting in September down in Colorado Springs, and I'm excited about that, to hear how all the projects are working and the advancements that you all have made and lessons learned. I also want to let you know that sitting here with us today too is that, I don't think we even let Maribel know, is that Sarah Kemp, our new coordinator for CPAC, is here with us today. And so if there's some follow-up afterwards, please feel free to contact she and Brian, and they'll offer opportunities for that. Just a quick, I think I should give a quick overview of who we are as an organization. We represent Colorado Behavioral Health Care Council, and in case you don't know, we are the membership organization for all of the community mental health centers in the state. For all of the behavioral health organizations, they're the ones that have the contracts with the state Medicaid program for managed care. And then also we're the membership organization for all of the managed service organizations, and they have managed care contracts with the state of Colorado for substance use disorder. So we're really a provider organization, and looking at representing behavioral health providers across the state. And we've been in existence for 46 years, so we've got some experience under our belt, and I've been here for 12 years. With that, I want to tell you that we went on an adventure a little over 5 years ago, and we started talking about what does the future have for behavioral health. And it became very clear to us that integrating behavioral health with physical health was really going to be the way that the way of the future. And how do we move forward in that endeavor? And so, as many of you know, as behavioral health professionals and our businesses, they were set up very isolated from physical health care. And if there was coordination, it was really through localized efforts usually that really, when that did happen prior to this. So the next step for me was to go out and start meeting physical health providers, movers and shakers in the state that really were interested not only in physical health care and leaders there, but people who also had similar insights to ourselves. And of course, I met many of the people who you've met through Advancing Care Together, Larry Green and Frank and Maribel and Ben and the whole group over there, but also began meeting some physicians that were in practice, or overseers of large practices. And we just started asking them, what is it that you guys need from us? And there were a series of things, but one of them that came out in virtually every meeting that we had was, we need somebody who understands psychiatry. We need a psychiatrist who would be able to help us as we prescribe medications, as we consider medications for our patients. And we had heard that enough that we thought, it's pretty hard to ignore when you get a common theme that comes through from everybody. And so we started getting excited about this. And one of the entities that's partnered with some of our members is Value Options. It's a national managed care company for behavioral health. And they sit in a lot of our meetings, and I was talking about what I was learning, and they said, well, my goodness, we have something like this going out in Massachusetts that we've been doing out there that's been very successful. So I invited the people from Massachusetts out, got really excited about this, and then it's taken us this long to really get the funding and the opportunity to move forward with this, the consultation project. For a period of time, we were working real closely with the Psychiatric Society, and they were hearing the same thing from their communications with people they were meeting in the community, and we really are excited about them also being a part of our advisory committee for CPAC. So anyway, we've got a lot of excited people here about what the potential is for this project and how it can integrate care. So what was interesting in our first meeting after we got the money, we were sitting down together and we just started having some general discussions, and we started talking about the psychiatry in the practice, and one of our partners looked up and said, isn't this really about redesigning care? Isn't this really a different way of looking at providing overall health care? And what we're providing is one of the tools that's really needed for that to happen. And boy, I mean, it just really got me excited, because I tend to focus sometimes down into the specialty and not see how the specialty really makes a difference on how we can change the way healthcare is delivered. So as Brian presents, as we talk about this, we will talk about the psychiatric consultation piece, but please look underneath from our mindset. Maybe this is our way of being able to contribute to the changes that will happen in this state to integrate behavioral health and physical health care. So with that, what I'd like to do is turn this over to Brian so he can tell you about the CPAC program, and then we can capture some of the questions that you have. So Brian, with that, I'm going to turn it over to you. Thanks.
Thank you, George. Good afternoon, everybody. Again, my name is Brian Turner. I'm the programs manager here at Colorado Behavioral Healthcare Council. And George just did a fantastic job at kind of laying the foundation for one of the key takeaways that I want to make sure everybody leaves with today, and that is why are we involved in this work? What is it that has got us here at CBAC and our project partners so fired up, and what can we share with all of you to hopefully get you excited and fired up about this project as well? And so we want to make sure you understand the why. We want to give you a clear picture of who's involved, what it is we're trying to do, and how you might be able to get involved after you hear exactly what it is we're proposing. So I'm going to take you into the detail a little bit about the project. And so again, it's the Colorado Psychiatric Access and Consultation for Kids Project, or CPAC. And I guess I'll start by saying you're welcome for giving you yet another acronym to add to your long list that you can memorize and impress your friends and family and colleagues with. We didn't see any way around it. CPAC's a good one, and hopefully it's memorable for all of you. This is a 2-year grant that we got through the Colorado Health Foundation. We are in the implementation phase right now, so really just getting started, getting all of our agreements in place and our personnel hired up to get the project started. So everybody here on this webinar is really on the front end of what we're trying to do, which is an exciting place to be. The key project partners that are coming together to make this project possible, of course, the Colorado Health Foundation is our funder. Value Options is a healthcare management organization. They cover and work with the BHOs in a lot of the regions around the state. Colorado Access, of course, a health maintenance organization based in the Denver area. The Reach Institute is our training provider for the program. And then George already mentioned CBHC and the folks that we represent as a statewide association for community behavioral health. I'll get into more detail on each of the individual roles of those partners. We've already convened an advisory board for this project, and so you can see there's a lot of just fantastic organizations and associations, direct providers that comprise this advisory board, as well as the relevant state agencies that really have key roles in oversight, policy, and the way that healthcare is designed and delivered in this state. These are the high level, what it is we want to achieve. And so George, kind of got us going in this direction, but these are kind of those really thought out and articulated exact deliverables that we want to achieve. This would just be the ideal for us. And so we're seeking to promote systematic, evidence-based mental health screening across family care practices, pediatric care practices in Colorado. We want to improve access to treatment for kids with behavioral health issues. So that's not only access to have behavioral health needs met in the primary care practices, but also making sure that there's linkages to behavioral health providers where the level of care dictates that need. We want to increase the capacity of the primary care providers to deliver mental health care independently, and then again to refer out to those local specialists when needed. And so, we built in training, we built in consultation, and I'll get into those details, but those are the types of things we want to do to make sure that kids can be retained in the practice as long as possible, but that we're also creating access to a full continuum of care as appropriate. Develop well-functioning relationships between the pediatric prescribers that are going to be a part of this project and the child psychiatrists that we have a team of to really provide ongoing consultation. And then, of course, that relationship extends to the behavioral health providers that would be referred out to. And we want to assure that the psychiatric resources that we have in the state are really effectively dispersed and deployed. There's a workforce shortage. There's challenges in meeting the needs for this population, and so it's an absolute priority. And that was one of our highest motivations for getting this project going. That we want to do something in that area. A little bit more of the number side of why we want to do this. George spoke from a pretty high level. If you're a data person, like numbers, like I do, it's estimated that between 15 and 25% of children and adolescents seen in pediatric primary care practices have behavioral health disorders. That can include significant psychopathology, high functional impairment, and frequent psychiatric comorbidity. And so in Colorado, that translates to over 250,000 kids with a diagnosable mental health condition, 80,000 of which may have a severe emotional disturbance. And I mentioned the workforce, but there's also really a limitation in training and in time and in establishing and fostering strong working relationships between primary care practices and other levels of care, their counterparts in community behavioral health. I know that I'm talking to some innovators out here, so I don't want to make it sound like a lot of primary care practices aren't already doing a lot and haven't already taken the initiative to improve their efforts in detection, management, coordination of child mental health care. But again, there's a number of challenges that persist, and we want to be a part of really fostering and strengthening your current efforts and building new efforts where there may not be anything underway. So going into a little bit more detail about what are we talking about? What are we saying we're going to do here? So I'm going to kind of lay it out here. I don't want you to get into necessarily a linear kind of path of thinking about how this all rolls out, but I'll go through the separate components that we've proposed to put in place and that we'll take on. So first and foremost, provide evidence-based trainings to the family care and pediatric practices that we enroll in this project. Evidence-based practices on behavioral health diagnosis, treatment, medication options for the prescribers, and then supporting that training with an ongoing curbside consultation service, a telephonic consultation service. We want to, again, increase the skills and resources of all of our practices enrolled in the area of assessment and screening for mental health for kids. And it's not just a one-time, kind of one-shot training. We will be providing ongoing consultation and kind of a level of technical assistance with our training provider directly to the practices to make sure that the training is taking hold in those practices. George talked about kind of changing the way care is delivered, and you all know that a one-time training doesn't get that done. You need constant, you need ongoing consultation and support in implementing the concepts you gain through that training. That takes us into that supporting practices bullet. We do want to retain the children in the practice, as I mentioned before. It's about arranging referral and facilitating a warm handoff to the other community-based behavioral health care resources that are out there when it's appropriate, when it's required, and building an ongoing relationship so that it's not just a one-way referral out, but that the services and the treatment that kids receive in the behavioral health setting connects back to the primary care provider, and a relationship is established, and there's some collaboration ongoing for really to enable the best treatment possible for the kid. So this is a proof of concept grant. It's a demonstration. Our intention is absolutely to extend this statewide, but we got to prove we can do it first. As you all know, the Colorado Health Foundation, as all good funders should be, are very focused on evaluation, on proving that what you're doing is making a difference in the population that you propose to help. So the two regions that we'll be extending this project to is a Denver metro region, and that's really going to be facilitated by Colorado Access. They'll take a lead role in recruitment of practices, in coordinating care between primary care practices and the behavioral health providers within that region, in managing and tracking data for the child psychiatrist teams that are going to be providing telephonic consultation. And then the same kind of role exists for value options in Region 2, which is going to be a kind of southern swath of Colorado. You see the big star hovering over Pueblo County, but it really extends down throughout the southeast corner, throughout the I-Chip, Rico, and into the San Luis Valley. Again, getting down into the activities level of what we're proposing here, the absolute foundation is partnership. We need strong partners in this effort. It's a relationship that's going to be ongoing for a couple of years here, and we need to make sure that everybody is on board and kind of committed to the same vision and goals. There's training provided, which leads into the ongoing consultation, the collaboration that I continue to kind of harp on, and then, of course, the evaluation. Is what we're doing actually working? And, you know, kind of like the PDSA cycle, that evaluation feeds back up into each one of those individual components. We want to be studying where we can improve the project, where we're having success, and know where in the kind of chain of activities we can make tweaks to improve it. I mentioned, you know, the importance of partnership. We're looking for practices that are kind of committed to this value of creating a system of care that is focused on whole health, is focused on integration, committed to improving the way care is delivered. I throw the little picture of the guy rolling up his sleeves, and I don't want to like give the impression that we're creating kind of an onerous commitment for anybody, but we're looking to select practices and partners who are willing to kind of roll up their sleeves, do a little bit of work, and committed to making this a success. You know, it's not just a one-time training opportunity. Again, this is an opportunity to get involved and do something big, and you know, admittedly pretty ambitious for the state. The training component, to get into the detail about what exactly that consists of. I mentioned the REACH Institute. They're our training provider. They are going to be delivering two separate trainings, one focused on the family and pediatric prescribers that we enroll in the CPAC project. It's called the Triple P training, so Primary Pediatric Psychopharmacology. Again, another acronym, you're welcome. That's a 3-day training, and it's focused on evidence-based training, focused on proper assessment, diagnosis, medication management, depression, aggression, anxiety, ADHD, bipolar psychosis, the things you're going to see in your practices that you already do see in your practices, and giving you a comprehensive 3-day training so that you're better able to address those types of behavioral health needs for the clients you see. I'll mention that both of, I'll go into detail on the second training also, but let me just mention that there is a series of ongoing kind of consultation calls that are going to be built into this. So in addition to getting that training, there's going to be the opportunity and indeed expectation that involved practices will then get to benefit from the ongoing expertise of the REACH Institute in implementing those concepts. On the behavioral health provider side, we are providing the child and adolescent training in evidence-based psychotherapy, the CATIE training. This is a 5-day training. We don't presume, we're not offering this training because we believe there is an utter lack of evidence-based training or expertise in the behavioral health system. But this is a very comprehensive, indeed evidence-based training on all of those different diagnoses that you see right there. It's building up the capacity in each of those, for each of those behavioral health providers in the practices. It's making sure that everyone's working kind of from the same page on latest and best practices in evidence-based therapy. And then by providing those two trainings, the hope is that the primary care and family practices will then be connecting to the behavioral health providers that go through the CATIE training. We're going to be offering mini fellowships for all of the providers that we select to participate. So, you know, not only are these trainings free of charge, but there is an incentive to the providers to attend. And then another component that I'll spare the details right now, but there is train-the-trainer opportunity so that we can really focus on sustainability and building in long-term capacity to provide these types of service. A little bit about the trainers. The REACH Institute was founded a number of years ago by Dr. Peter Jensen. He currently works with the Mayo Clinic, formerly with NIMH and Columbia University. A very smart guy, and has just had tremendous success since establishing the REACH Institute, whose mission is really to improve the mental health of American youth. And they do that by training pediatricians, family practitioners, child psychologists, all those different professions you see on the screen in the latest, best evidence-based practices in mental health. So you can Google the REACH Institute if you want to learn a little bit more about everything they do. Yeah, and I believe their executive director, Lisa, is on the line. So if people have some really specific questions about any of this training or the REACH Institute, we have an opportunity to have Lisa address those for us. The next component after training is that ongoing consultation. So we mentioned the kind of technical assistance role that the REACH Institute plays, but having access to real-time consultation with a team, with a child psychiatrist within 30 minutes of any request during kind of 8 to 5 business hours during the week. Our goal here is to link practices and build relationships with specific child psychiatrists so that the prescribers that are in the project are not just calling a random line and talking to a different person each time, but they're building a relationship that is going to really be beneficial for a long time. They feel comfortable with the person. They can trust the expertise and consultation and advice that they're receiving. This, again, is a curbside consultation, and that's actually kind of a technical term, so if anyone has a question about that, I can go into that. Absolutely key is the collaboration piece, if you haven't gotten that already. I put this together mainly because I needed something to go around this little illustration I found of myself 20 years ago, but also just to illustrate that, again, this isn't a linear project. We're really talking about offering training, building in ongoing consultation, making sure that the care for the kid who's at the center of all this is connected and is ongoing for all of the providers involved. And CPAC also brings in that level of coordination. So Value Options and Colorado Access will have regional care coordinators to help bring this all together for you. So you're not calling different practices trying to get questions answered. You have a designated liaison and coordinator who can help you in referral process and accessing call center and understanding where the project is at as a whole. And then the last piece, again, is evaluation. So specifically, we're proposing to do research on health outcomes, cost outcomes, and a detailed process evaluation. You can see some of the questions that we're looking to have answered. This is a very ambitious evaluation effort. We understand that. We are excited to be undertaking it. We have a tremendous amount of just professionals and experts at our disposal who have not at our disposal, but who have graciously offered to step up and help in this effort. There's been research done on teleconsultation models and similar projects like the Massachusetts project done across the country, but we're really trying to get at the long-term or at the true health impact of this project, and we need to make the fiscal case for that. And of course, once we get our outcomes, we want to know why it is that we had those outcomes. So that's where the process evaluation comes in, making sure that we're learning lessons and able to continuously improve our efforts to realize the outcomes that we think this project is capable of achieving.
Now, Brian, before you go into getting involved, let me just sort of pass a couple of thoughts on here. Number one is that this isn't the offering a 1-800 call the shrink line has been around for a while. It's not, but we've even tried that here in Colorado. We've talked to some of our members who in their communities actually offered a number that people could call, and they very rarely get calls. And one of the things that we were looking for is why some places are successful and why some places aren't. And the places that have not been successful, the major issue was they didn't have all the components in place that you brought forward. And I think that that's really important for people to understand that we didn't want to just offer a line. We wanted to offer something that would really make a long-term difference, that people would get comfortable in learning and and begin to have an important part of their world. The second part, which we sort of alluded to, and I want to make sure people know, we do want this to go statewide. Our initial plan was to go statewide right away, and then reality hit that we got to start someplace. We are already in discussions with the Colorado Health Foundation with an expectation that if we're successful, that we'll be coming back for 3 more years of funding to take this statewide, and then hopefully someday in Colorado there will have been established a model. A model has some level of sustainability to it, to where this would be available for pediatric docs or prescribers that they'll have, that'll be available for them over the years. So this does have a long-term feel to it. We hope that it's not just a 2-year grant and we're out the door. Our plan is to have something available for Colorado on a very long-term basis. So let me turn it back to you, Brian.
Thanks, George. And one of the other really important pieces that reminds me of is that when we're talking about kids served, we're not talking about just Medicaid kids. This extends to all payer types. So public, commercial insurance, uninsured, whatever it is, this is a service available for all kids. Something that's very important to the Health Foundation, very important to CBHC and all of our project partners. So just wanted to make sure everyone was aware of that. I think that that's probably, hopefully, enough detail and not too much detail to get people excited, interested, and generating some questions. I'll let you know that if you're interested in getting involved, either as a pediatric prescriber, somebody who works with pediatric practices, family care practices, or if you're a behavioral health provider interested in going through that training and serving that role as receiving referrals from these practices involved in CPAC, contact Sarah Kemp, who George introduced at the beginning. She's our CPAC project coordinator. Her contact information is there. Reach out, get in touch, and we'll talk about what the opportunities and possibilities are to get your involvement. And then finally, I'll just include, and these slides will be made available, but just Sarah's contact information again, and then George and I's contact information. Any one of us would be really happy to talk with you about the project and potential roles and where we elaborate on anything we've already discussed here today. So that brings us into questions. And Maribel, I'll turn it over to you to kind of facilitate that process for us.
Thank you so much, George, Brian, Sarah, for that wonderful presentation. What an exciting program CPAC promises to be. So I a couple of things that I wanted to ask, but I don't want to go first. I certainly want to give our attendees an opportunity to get their questions answered. So let's see here. It looks like the question, what is the big difference in caring for children in this manner and doing the same thing for adults? Is there a difference?
Well, I think that hopefully I'm understanding the question correctly. To me, there may be differences, of course, in the clinical approach that you take when treating kids versus adults, but the concept is the same. I think that we're talking about integrated care. A level of connection between behavioral health and physical health is something that absolutely across the lifespan should be made available. George, do you want to elaborate on that?
Well, and I think this type of work will expand more than just with children. But one of the things that we've learned, and we as a matter of fact, we expect it will. But I will say this, that with kids, one of the problems is the off-labeling issues that happen with those medications, and it's not such a clear pattern to use. The best practices aren't as refined as they are with adult populations, and so I can understand how a pediatric doc would be in a situation of going, man, kids are often prescribed multiple medications, or why are they using this one? There seems to be a lot more questions, but I mean, let's face it, if you haven't been trained in psychiatry, you're going to have some questions even with the adults. But I would say that's the reason why, and again, it is narrowing it down that, you know, to certain populations, we just, when we would look at, there are different certifications for psychiatrists, and a child psychiatrist often will know about adult medicines and vice versa. But to be honest with you, we're focusing this on having psychiatrists who have kids certification, children's certification, that really understand that area. I hope that's helpful. If there's additional questions, please submit them.
That makes a lot of sense. Any other questions? So just want to remind everybody, you can either submit your questions in writing by just typing them in your little question box, or you can raise your hand and I will unmute you so that you can ask your question verbally. And I don't see any raised hands right now, and I don't have any other questions, so don't be shy. Go ahead and submit your questions either in writing or raise your hand to ask your question verbally. And while we're waiting for that, I'll ask a question related to the timeline for implementation. So it sounds like you're starting in a in 2 focus areas, geographically speaking, in Colorado. What is your time frame for having the practices selected in those areas for you to start the implementation of CPAC? And also, how many practices are you looking for initially?
That's great questions. Over the next 12 months, we're going to be providing kind of several different training opportunities. So really what we're looking for right now is kind of a group of early adopters, folks who are ready to jump in, who are poised and prepared to get involved with the project. And we'd like to have that recruitment process and training delivered by November is our goal for the first training for both behavioral health providers and in the triple P training for prescribers, pediatric prescribers. There will be additional training opportunities later in the winter, spring, and possibly early summer, depending on how our recruitment process goes. We want to have all of the practices enrolled and in place so that we can be moving forward with the evaluation and seeing some good outcomes as quickly as possible, but that's all year 1 activities.
Okay.
And then as far as how many, we're looking to, between the 2 regions, select up to 85 prescribers to participate. That doesn't necessarily mean 85 practices. We're working with our training provider to nail down exactly kind of what is that critical mass, how many prescribers, how many providers within a practice is enough to really help that practice realize the kind of change we're talking about and implement the concepts that we're talking about, rather than just one person getting that training in isolation within their practice.
Right.
And then on the behavioral health side, up to 35 behavioral health providers would go through the training. So more on the family and pediatric side than the behavioral health side.
And if I could add, because both Colorado Access and Value Options are involved in RICOs, and I want to remind you that this is not only a Medicaid project, but the fact is that they already have some connections with physicians who are asking and wanting to be a part of this. And Maribel, as you might expect, Steve Poole, who's been working on this area for a long time, is quite excited and seems to think that he has some practices that are interested in getting started right away.
Of course. Yep. I have another question, and if there is a more formal process, I think it'd be helpful to know, how do we apply to be in the program? Is there an application process, or is it as easy as just kind of starting a conversation with one of you guys?
It's as easy as starting a conversation at this point. We will absolutely be there'll be a series of kind of meetings and ongoing communication to really make sure that we have the right fit, that both sides are understanding kind of where the other partner is at with the project. But to get involved at this point, reach out to Sarah Kemp. Let her know you're looking at the opportunity, and that will begin a conversation to move forward in actually putting an agreement into place to participate in the CPAC project.
Okay. Next question. What is the projected time when evaluation results can be shared?
Well, a big piece of year one is very clearly defining the entire research design and evaluation effort. So when it comes to measuring things like health impact and health and cost outcomes, some of that is going to be more challenging to get very quickly. When it comes to uptake, those kind of quick metrics and data collection so we can measure utilization of the program, those are going to be available as soon as the program is as soon as we're operational. So it all depends on exactly what outcomes you're looking for, but we recognize that in order to get really solid health outcomes, you're talking about a longer time horizon.
Sure, but for the early results, it sounds like those will be made available as soon as you have the answers to those more process-oriented outcomes. How do you plan to share those?
So absolutely, there will be a continuous loop back to anybody who is a part of the project and providing data and playing a role in the project. We'll be getting monthly data reports as the lead on this project that we'll have access to and can compile and then provide reports back out to the project partners. George, do you have any thoughts on that one as well?
Well, I think that, Maribel, I'm really glad that somebody asked that question because I don't think we've addressed it as clearly as we probably need to, so thank you. And others are going to be interested. We obviously have reports back to the Colorado Health Foundation. We'll have to time what their expectations are of us when we release information or not. Mm-hmm. But my guess is that we're going to move towards looking at having something available on our website and such where people can, find this out. So I have to tell you that I think we've been thinking about certain things, but that is not one we've nailed down. I would like to share something, if I might, with the group, too, that's still on the phone. It's really important to understand that right now there's really no payment mechanism that's out there to do this type of project. This is something we really need a foundation to help us get it off the ground. But frankly, if you look at it from a fee-for-service perspective, there really isn't the codes and such that really work for this to be paid for. Or if you're looking at other funding models, what we've got to do is prove to somebody who might be doing a global payment model or a bundled payment model, looking at private sector, whatever, to see that it makes sense to have some way of being able to pay to have this available to primary care physicians that want to have this as part of what they need to see kids, to work more with kids, and to get the behavioral health issues out there. So there's sort of an ulterior motive here in a way that we not only want to show that it works and it works health-wise, but that it's worth funding. And that's also part of what the Colorado Health Foundation is invested in us trying to find out.
Sure, that makes sense. And speaking of payment, I think you may have just answered that question, George, but I'll go ahead and throw it out there just for clarity's sake. The question is, would prescribers and therapists be reimbursed for their time?
So in terms of time, there is, again, the fellowships available for the time that they spend participating in training activities. Okay. But as George just mentioned, there's no billable codes for, say, calling the child psychiatrist.
But there
other than
for the curbside calls.
Or other than what may, Maribel, other than what may be available on the primary care side that we're just, we're not aware of yet or understand on when they make that consultation call, how they can get reimbursed. There's so many one-day payment issues and matters in mind. I just don't know how to narrow through. I think we're going to do some learning.
Yeah, absolutely. That makes sense. It's helpful to know though that there are some funds for the training aspects of it. Um, how is the information provided to the PCP documented? Not sure I understand that question. Maybe you will.
If that is a question about
And then
like,
it's any liability concern. So I think it's a question.
yeah, so that's where I thought that question was heading. Is it's a curbside consultation model. There's not PHI exchanged. It's not patient-specific consultation. It's curbside, meaning that you're getting general advice on, you know, general advice on the diagnosis side on how you would address the problem, but it's not a client-specific PHI exchanging kind of consultation model. So therefore, there isn't the same level of liability.
Got it. Okay. Next question. I work for a nonprofit child adolescent mental health provider contracted by CMH in Michigan. We would love to utilize a similar program. Although I'm aware of the Michigan Child Collaborative Care Program, MC3, it presently only serves another county about 60 minutes away and the northern part of the state, significantly further down from our locale. What suggestions do you have for an individual organization to collaborate with a collaborative such as that I mentioned previously and the one you're presenting on today? So this is somebody from out of Colorado.
Well, I don't know if I got the total answer, but let me share one thing is that with the wonders of technology today, one thing, and because it's a curbside consultation, it really starts opening up some doors of what could be done across state lines and really across regional lines. And I know we've taught, if you notice, Brian showed you the picture of the phone. Interesting, it's a smartphone. And our plan is that we eventually want to see this also be video.
Yeah. And
we're working on a project right now where we'll have a video product that's available for whoever's connected to CBHC in one way or another, that will be able to do video back and forth. So we do see that starting to happen, and I think that what I would do if I had an interest in that project is just go and start encouraging them to say, have you guys thought about maybe going outside the area? I know we're going to get some pressure with that on this right now. I know we're going to have folks say, look, you just drew the line, but my practice is right across the street. We're just going to have to deal with that. But I do believe that I think bringing the case to those folks is important. I think there's also a business model here. And that's what I've been thinking about on my end, is that I do believe that there's a possibility that in the future we will see businesses that are focused on doing this. That it may be that there'll be a Colorado CPAC, that it doesn't have anything to do with CBHC, it's a group of providers who've come together and figured out a way to do it. It could be regional. And I think that right now people are just so much focused on what's going on in their local area, in their region, that they're not looking at the potential of this being bigger and broader than just in their local community. So we're already talking about, I'm trying to look 6 or 7 years down the road or whatever, where we in Colorado have a cadre or different cadres that people contract with or have MOUs with or whatever in order to be able to support them.
Great. And I think this may be our last question. Basically, it's would a prescriber or therapist be asked for consultation only by PCPs in their community, or could someone in Fort Collins, for example, be asked questions by someone in Cortez?
So the hope is, as we kind of mentioned, to really build relationships between the child psychiatrists and the prescribers that they're there to consult or to provide consultation for. And so it is telephonic, so there's going to be probably a degree of geographic separation, but the goal is to build a relationship that is ongoing, and they're child psychiatrists that are really recruited out of the two regions that we're talking about. It's also important to go back and mention the role of the care coordinator, because when it comes to then referring to the behavioral health providers in your community, it's important that obviously those are in your community. It's of no use to connect with behavioral health providers that are on the other side of your region or in another region. And so the care coordination is a really important piece in making sure that the healthcare delivered is local and makes the most sense from the provider perspective in terms of who does business in their community, but also from the client perspective in terms of how can they best access the care that they need.
Sure. Sure, that makes a lot of sense.
Any other questions?
Any other questions? We have a few more minutes left if you want to submit any other questions, or if you want to raise your hand, and I'll just do another quick check here.
Well, Maribel, I want to say thank you for thinking that this might be something you guys would be interested in hearing about. We're surely excited, but we're on a learning curve with this. We think we've got a strong model. There's a history of it. We believe that what we're going to try to do here in Colorado is going to be very successful. This isn't on a, something we just sort of dreamed up one day on the back of a napkin and put together a program. But at the same time, we've got a lot to learn. And so what I would like to ask is that if as you maybe participate in this, or you have some thoughts on some things that we may be missing or that we might want to consider, we would surely like to learn from you too. There's this whole idea of integration and really providing integrated care in a community base that Brian has done some mention with. We've all got a lot to learn, but the good news through Advancing Care Together and other efforts that are going on, we have over 130 sites here in Colorado. Some of them are Advancing Care Together sites that are connected in some way to CVHC. This is going on around our state, and there's so much opportunity for us to learn together. We hope we can be part of the learning community of Colorado, what we learned and what you're learning to help us. So thank you very much.
Thank you both. There are no other questions. I did a last check, so I guess that brings us to the end of our webinar. I want to thank both George and Brian very much for the excellent presentation. Wish you much success with CPAC. We think it will be incredibly successful, and we will learn tremendously together about what it does take to integrate care. So thank you again to everybody who joined the webinar, and until the next time, bye everyone.